presentation will be done by Mr. Zubin Master, and he will speak on experience of rare metaplastic breast cancer case series. So Mr. Zubin Master, can you please come forward and have your speech?
Therapy in the next few years. Okay, so I've trimmed a lot of fat from my slides, so I'll just get straight into it. So the current standard of care that we have for breast cancer is mostly 3D, VMAT, and tomotherapy, and we are slowly trying to push forward and get into proton therapy as well and get approval from our Ministry of Health. So I will just talk about the current standard of care that we have right now. So all our cases in NCCS who undergo breast conserving surgery and mastectomy will get some form of radiotherapy, either whole breast or chest wall radiotherapy. And the choice to give regional nodal irradiation kind of depends on the staging, how many positive nodes, the risk factors, and very often if we only have a sentinel lymph node biopsy that is positive and we don't have the full axillary resection, we will kind of make a decision based on the NSKCC breast nomogram to determine what kind of what the likelihood of positive lymph nodes would be. So the decision to include the SCF in the RNI volume would kind of depend on the nodal status, so N2, N3 disease, and also high risk N1 disease would warrant including the SCF in our irradiation volume. Including the IMN would depend upon, again, on the nodal staging. It would also depend on if our tumors are more medial and centrally located. And also the inclusion of the IMN has to be balanced with the fact that there will be increased cardiac dose. And over the last 10, 15 years, there's been a lot of data suggesting that treating the IMN gives you better disease control, better long-term survival. So our practice has been to include the IMN for a certain staging and above. Including the axilla depends on, again, if the dissection was clear and complete, and if it was not clear, we will include the axilla in the treatment volume. We also do partial breast irradiation for cases where the risk is low, when the patient is young, tumor size is small, the grading is low. And the rationale behind partial breast is that most of your recurrences happen locally in the tumor bed region, and for when we're not treating lymph nodes and the tumor grade is low, we will opt for partial breast irradiation. And also we can consider accelerated partial breast irradiation, which we deliver within about five days, either 10 fractions BID or 5 fractions. And our approaches to APBI is normally just conformal or external beam therapy. We also have an IORT program and a brachytherapy program, but the number of patients that we are recruiting on the IORT has become very, very low. So it's mostly just external beam for APBI as well. The fractionation that we've been using since about 2012, 2013 is, we used to do 50 gray, 25 with a 10 to 16 gray boost. We have now switched to 40 and 15 for almost all our cases. And ever since COVID started, cases that do fit the criteria, we will use fast forward and treat them in 5 fractions. And of course, we do APBI as well, which will again be in about between 26 and 5 to 38.5 in 10 fractions BID. Okay, so I'll just quickly go through the external beam techniques that we're using. So we're using 3D for most of our cases, I would say majority of our cases. And we treat 3D with 2 field tangents, and we will include a 3rd or 4th field if we're treating the SCF and the axilla. We do field and field for almost all these cases. We don't do IMRT for these, and if we really need advanced conformity, we will just go to VMAT or tomotherapy. And of course, we're trying to start doing start a proton program for breast as well. Okay, so just a quick overview of how we do our breast tangents. So we always use half beam blocks so that we don't have to match the divergence of the beams in the chest wall. We will usually use a skin flash of about 1 centimeter. We will do field and field for most of our cases, or wedges, whatever gets the best dose distribution. We would normalize in between basically in between the chest wall and the edge of the breast volume, and we will normally use a heart shield to bring the heart dose back to normal levels and below tolerance doses. And the heart shield is usually just included into this field, and if the dose is really non-meeting, we would include the heart shield on this side as well. For our boost, we either do an electron boost, so we use either custom cutouts or standard cutouts. We treat at 100 SSD, usually a single energy, or we do mixed energies. We can also do a breast boost with mini tangents, so it's very similar to tangents, except we don't have to, we don't really have to match the divergence, and we can use slightly different beam angles to get better conformity on the target. Now going to 3-field and 4-field, if we need to treat the axilla and the SCF, we will use quarter beam blocks. So what you can see over here is this half beam block matches the divergence for the other tangent, and this half beam block over here matches the divergence for the SCF and the axillar field. And apart from that, it's very similar to how our tangents are treated. For the anterior and posterior SCF and axillar field, we will, again, as I said, we will use quarter field blocks. So this is matching the divergence to the tangent field that is sitting down here. And we would normally put a humeral head block as well, so we block the head of the humerus over here. And we will normalize the anterior field to a depth of about 1.5 to 2 centimeters to bring the dose up and make sure it covers the target volume that the doctor wants covered. And for the posterior field, we will normally normalize at NPD, and we just play around with the normalization to get the dose to where we want it to be. So now, why do we need to move on to these more advanced techniques? It's basically an issue of geometry. So it's not really the tumor staging or anything like that. It's as the target becomes more and more complicated and curved, and it's, in cases like this, you can see it's curved around the lung and the heart. And to treat this kind of volume, we would end up treating a lot of heart, a lot of lung, just to get coverage of the IMN and the chest wall. So these advanced techniques are really needed for more complex geometry rather than advanced disease. And as I said before, including the IMN has become part of our normal practice, because we've seen that it improves tumor control, long-term survival, reduces recurrence rates. So once you add this into your volume, you have a small percentage of patients who do require these advanced techniques. So this is not required for all patients, but there's a small percentage that do require this. So techniques like VMAT, tomotherapy, and protons come in, which can help you really curve the dose around your OARs and get you the target coverage that you need. So so I'll just go through the VMAT technique that we use. So this is about the angles that you would want to cover in your VMAT. And within this arc, you might want to have multiple arcs in there. So we have pretty detailed SOPs on how to do this planning. And all our dosimeters do something different. They don't really follow the procedure. So we have a bunch of techniques that our institute is following. So a lot of our doses just like to do 3 complete partial arcs, and they don't have to think too much about how to split up the arc, and it's quite easy to plan this way. It's fair enough. It's not bad. Then we have some who try to cone down. So we have like techniques where they use 2 partial arcs, 1 mini arc. Some of them use 1 partial arc, and then they have 2 sub arcs and you normally sequence these arcs in such a way that it's easy to deliver on the unit. So you would start your arc over here, arc 1 would go up to here, the next arc would be the full partial arc, and the third arc would end over here. So it's easy to deliver, and you can sequence these fields quite easily on the machine. And similarly, this is probably the most coned down, where you only have 2 partial arcs over 2 mini arcs over here, which treat the edge of the breast, and you have 1 big arc over here, which kind of fills in all the extra dose that the 2 mini arcs were not delivering. Similarly, for our boost, we deliver 2 partial arcs usually. So there's 1 arc over here and 1 arc over here. And this is usually sufficient to give you a pretty good dose distribution on the boost and still spare the lung quite well. Okay, this is, so this was VMAT. Now we use tomotherapy as well, which we retired a few years ago. But I'll quickly go through the planning. So tomotherapy delivers dose 360 degrees. It doesn't have any beams or anything. So you have to kind of specify to the system where you want the beams to come in and where you don't want the beams to come in. So what we use are these kind of blocking structures, which you have to draw manually. And as you go through the volume, you just keep changing the shape of your blocking structure and telling the system where your beams are allowed to come in, where your beams are not allowed to come in. So here you can see that we block this side and this side, so all your dose comes in just from the front and the back. Then similarly, as you go further inferior, you can see that we don't want dose coming through the lungs, and we just allow the dose to come in from this part of the volume. And we go through that, and you end up getting a dose that's quite nice actually. So this is the 4 gray line that you're looking at. And yes, the dose does go into the low dose does go into the chest wall, but it arcs away from the heart and the lungs quite well. So we can spare the lungs and the heart quite nicely. Okay, so then there are a lot of things you have to think about when you're doing your VMAT and total planning, because the dose really is like a balloon, and wherever you push the dose somewhere, it's going to push out somewhere else. So you have to make a lot of dumping structures and dummy structures, and you can't just expect to spare the lung and the heart and expect everything else to be okay, because it is going to go into places where you don't want it to go. So I'll just go through the volume where we actually look at the dose. So in the most superior region, we normally try and block out the humeral head. And when you do that, it will try and dump dose into the midline. So you have to also look out at the midline. So we push the dose outside the midline, keep it away from the thyroids, the larynx, the esophagus, the constrictors. And a lot of these patients, if you don't do this, these patients will end up getting dysphagia. So you have to kind of think about all this when you're doing your VMAT planning. Then as you go further down, yeah, you just have to make sure you're pushing away from the lung, and it's going to dump dose into the chest wall over here, which is okay. Then as we go further down, you have the choice of dumping dose into the greater vessels, dumping dose into the contralateral breast. So this depends on different centers and different physicians. Some of them, like most of our physicians, don't mind dumping dose into the contralateral breast because they know these patients are going to be followed up for many years, and they will identify if there's a new breast cancer that shows up, but they don't want to dump dose into the lung or the heart because that's damage that you can't really repair. So that's the thought process that our physicians follow, but I've met physicians from Korea who would rather dump dose into the greater vessels or the heart. So basically, it really depends on what the physicians, what their thought process is. Okay, then as we go further down, again, we can choose to dump dose into the lung, into the contralateral breast. So we like putting the dose over here. And some physicians also would like to put some dose into the contralateral IMN because they feel that's the best place for your dose to go. So again, that's it's a planning choice, and you have to have a lot of DLVs, we call them dose limiting volumes, to kind of shape the dose and push it where you want to go. And again, as you go down here, you will usually, once you're pushing the heart a lot, you will have trouble covering this. So our physicians like to have the IMN covered quite well, so at the cost of a little extra heart dose. And as you go even further down, considering you don't have any more lung volume here, your VMAT or your tomo optimization is going to end up throwing a lot of dose into your liver, into your stomach, and spleen. So again, you need dose limiting volumes here to clean that dose up for you. Okay, I will not go into the VMAT skin dose part because I'll just skip this, but this is another thing that we do in VMAT planning. And basically in your 3D planning, you have your skin flashes. So you're taking care of some sort of breathing motion, some sort of uncertainties in the positioning. So in VMAT, what we do is we just kind of create a virtual bolus over here, and we assign a density of -400 to it, and we allow our PTV to grow into this. So the optimizer can actually put beams firing outside the body. And the reason that you need to assign a density is because if you don't, the optimizer is going to try and put dose into air, and it's going to go into a loop and make a really high-weighted beam that's over here. So you don't want that to happen. So that's why you should kind of assign a density there, let your PTV grow over here, and then do your planning. And then you can actually just recalculate that plan on the normal CT, and that is essentially going to be a plan that has some skin flash built into it. Okay, so the things you need to consider while doing VMAT planning, that the dose is going to go everywhere, so you need a lot of these small OARs that you would not care about in 3D. And you need a lot of dose limiting volumes also to shape your dose and push it where you want it to go. And you know, structures like the esophagus, thyroid, contralateral breast, even contralateral lung will get blasted if you don't really control the dose there. Okay, so now I'll just move on to our push to get protons working in NCCS. So as you can see, breast is by far the biggest site we're treating for women in NCCS. And when we got our proton program started, these are the list of indications we requested that we could treat on protons. And they came back with this list over here, and they have conspicuously not included breast for some reason. And it makes no sense because breast is being treated with protons everywhere. So we have basically been pushing to get breast approved as a treatment site for us. So, I mean, the rationale for breast proton therapy is the same as the rationale for VMAT. We basically want to get more cardiac sparing, spare the lungs, spare the OARs, spare the contralateral breast. And also, you must have noticed in all those VMAT plans that you saw that there's a lot of low dose spread all over the body. So using protons for breast reduces all that low dose spread as well. So there's really very little going against protons for breast. And also other scenarios where breast proton becomes very useful is when you're doing re-irradiation, when you're doing bilateral breast, the planning is extremely easy and it gives fantastic dose distributions. So basically the only way we can actually treat breast on protons is if we make a trial for it. So essentially that's what we did. We created a breast trial, and it's a very simple trial. We're not really investigating anything very complicated. It's modeled on the UK Parabel trial, which is basically a proton versus photon trial. So it's just the proton arm of that trial is kind of the same thing, where we are basically taking high-risk breast cancer patients, left-sided mostly, nodes more than 3 nodes, requiring regional nodal irradiation. So, you know, the complex volumes, high risk of cardiac toxicity in the future. So these are all ideal patients for protons, and it's basically designed for that. And so basically we're going to treat breast plus regional nodes, give a dose of about 40 gray in 15 fractions, and SIB either a 6 to 8 gray boost on top of that. And what we're going to do in this trial is we will basically be doing, it's essentially a pilot study for us to see if we can properly deliver proton therapy for breast. We will be doing weekly reviews and following up these patients for 5 to 20 years after that. And we will be monitoring cardiac, lung toxicity, assessing quality of life, obviously tumor control and all that. So the planning for protons is actually very, very simple. It's actually very easy to deliver breast protons. So it's usually 2 to 3 fields. They're fields that are perpendicular to the chest wall. We use range shifter on all these fields because the normal proton energy goes to a depth of about 4 centimeters. So you need to pull that energy back to the skin surface. So that's why I use a range shifter. And for protons, we optimize directly on CTV volume, and we use robust optimization on top of that. So we assume a margin of about 5 mm, which is what we use for photons as well. And there's additional uncertainty with protons, which is called range uncertainty. So we have to account for that additional uncertainty, but that's about it. So comparing, you have your VMAT plan, then the proton plan. So you can see that the coverage is similar, but you've lost all that low dose around the space. And honestly, that's all just looking at these images, I think that's all the justification you need. Because it's the same justification that we moved from 2D to 3D to IMRT to VMAT. This is just the next step in that. So you can see we spare all that low dose and we get very good tumor coverage as well. So just going through a few of the structures that we're sparing. So we are getting a good amount of lung sparing through the ipsilateral and contralateral lung. We're getting a lot of heart sparing, contralateral breast sparing. So you can see the heart sparing, we're getting a factor of about 5. We're going to less than 1 gray mean heart dose. Lung dose we're bringing down from about, again a factor of half. We're basically bringing the lung dose down by half. And also a lot of contralateral breast sparing and a lot of unspecified normal tissue that in the chest wall, which we it's just disappearing basically, which we don't really look at in any DVH or any dose-specific metrics. Okay, so the things that we have to look out for in proton therapy is protons don't do well with metal clips, with implants, with expanders, so we have to, any foreign object that's in the body, we normally get a sample of it, we measure it, we see the range, we see how the TPS models it, and we will override the material in the body. And if the material is too dense, because like sometimes these expanders have these really, really dense neodymium magnets in them, we will find a planning technique that kind of avoids it and shoots around it. Breathing motion is something that we were concerned about initially, but we realized it's not an issue because we've done a lot of simulations and we've done interplay studies where we simulate what the dose would look like with breathing motion over the treatment course, and you can see the spread of dose is negligible, so it's almost like it kind of smears out over the treatment. Things we have to really be careful of are seromas, because protons stop with range. So if your seroma becomes bigger or smaller, you're going to either underdose or overdose behind the target. So we have to have either adaptive strategies where we monitor this very carefully, or you have to just create larger margins, or you have to basically account for seromas and be very careful with them. And the one place I think protons is not as good as photons would be the skin dose. So this is anecdotal evidence, but we've seen some pretty bad skin toxicity in our head and neck patients. And maybe these patients would get that kind of toxicity on photons, I don't know. But we are very, very careful with the skin right from the beginning. So we're going to do some sort of prophylactic skincare with all these patients. We will be using these Mepitel films, which are used for wound care. Essentially, we'll put it over the patient's breast right from the beginning and just make sure that the skin doesn't break down over treatment. And there's some other healing gels which are used normally for burn victims and things like that, which we will be using prophylactically during the treatment as well. As I said, bilateral breast is also very easy to do with protons. It's probably one of the easiest deliveries that you can. I'm almost done. Okay, so bilateral breast is also very simple to do on protons, and you can see that you get rid of all this extra dose that you were giving to the chest wall. And that was VMAT. This is tomotherapy, similar reduction in low dose. And you can see again the sparing, we dropped the heart dose to less than 1 gray, we dropped the lungs and all the other structures around to a very, very low level. Okay, the things that we have to be very careful with in protons is CTV delineation, because in VMAT and 3D, you have the security of the dose bath, which is going to be all around, and if you have not drawn your CTV properly and you miss some areas, your dose bath is going to get it and you will probably be okay. But with protons, there's a good chance that if you missed an area, it'll get 0 dose, and your disease will continue to grow over there. So we have to be much more careful with our CTV delineation over here. There are LET and RV effects, which we are already modeling and accounting for, but we should again just be careful of that. Protons is very unforgiving if the body contour changes, so we have to be very careful about reproducing the body contour every day. And if a patient loses weight or starts swelling up or swelling goes down, we have to adapt the plan to that. It may not, the plan might break down. And as I said before, we have to be very careful of foreign objects inside the patient, and we have to model them properly. Protons is a very expensive machine, and people are worried about the cost effectiveness, but people have done a lot of modeling, and they suggest that once you account for the long-term cardiac toxicity in these patients, you might be okay with protons, or the cost might justify itself. And again, as I said before, you have to select the right patients. So we have a model-based approach that should, kind of helps us find patients that will actually benefit from protons. And once you refine this criteria, you select the right patients, and you also use hyperfractionated or accelerated hyperfractionation, you can further improve this cost effectiveness. Okay, so quickly conclude. It's important to select the right patients for protons. It's probably not suitable for everyone. For the majority of cases, 3D is perfectly fine, actually. Only when your geometry becomes more and more complex, you probably need these techniques like VMAT and protons and stuff like that. And you can significantly reduce OAR doses. And again, you can use a model-based approach to hone in and select the right patients who will benefit from protons. Okay, and since it's a breast thing, I will just quickly give a shout out to the breast cancer registry that we've been running for about 15 years in NCCS. And essentially all patients that are treated for breast under Singh Health get included in this registry. There are about 28,000 patients right now. We're tracking like hundreds of parameters per patient, and we're generating, I mean, we can generate and do a lot of research with this data. So we have a lot of different investigators who are doing something adjacent to breast, and they come to us for this data. And it's a very, very useful thing. So if you guys are just starting out now, I would suggest building something like this. It's something very useful. Okay, that's it. Thank you.